Good morning, good afternoon, wherever you are. Welcome to another live stream of emergency questions and answers for families in intensive care and intensive care at home. I'm your host, Patrick Hutzel. I'm the founder and managing director of intensivecarehotline.com and intensivecareathome.com. I'm here to answer your questions today. And if you have any questions, please type them into the chat pad or connect with me live on the StreamYard link that I just posted into the chat pad. I can see Jose has a question, but just before I get to Jose's question, what makes me qualified to answer questions for families in intensive care and intensive care at home? Once again, my name is Patrick Hutzel. I'm a critical care nurse by background. I have worked in critical care nursing for 25 years in 3 different countries, where I worked as a nurse manager in intensive care for over 5 years, and where I worked as a nurse manager in intensive care for over 5 years. And I've been consulting and advocating for families in intensive care all around the world since 2013 here at intensivecarehotline.com. I'm also the founder and managing director of intensivecareathome.com. With Intensive Care at Home, we are sending critical care nurses into the home for predominantly long-term ventilated adults and children with tracheostomies, but we're also providing home BiPAP ventilation, home CPAP, home tracheostomy care without ventilation, home TPN, nasogastric tube management, PEG tube management, central line management, PICC line management, Hickman's line management, as well as portacath management. Currently with Intensive Care at Home, we are operating all around Australia, in all major capital cities, as well as in all regional and rural areas. We are NDIS approved, TAC and WorkSafe in Victoria, DVA approved, iCare in New South Wales, and IISQ in Queensland. And we're also providing level 2 and level 3 NDIS support coordination. Now, keep your questions coming. Join me live on the StreamYard link. That is really the quickest way to get your questions answered. I don't bite. We're helping so many families just by one-on-one consulting and advocacy. Jose, I can only encourage you to click on the StreamYard link and talk to me directly. I will answer your question in the chat pad, but we'll help you with your issues much quicker if you talk to me directly. I don't bite. You don't need to go on camera. But if you look at other previous live streams, we'll be so much quicker in answering your questions. Also, I'll go for an hour. So I'll be finished in about an hour. The sooner you can connect with me here on the live stream, the better. I also want to thank everyone that's watching this on replay, because I can see every week we're getting a lot of views on replay. But, the quickest way to get your questions answered and improve your life instantly is to talk to me directly. Okay, so Jose, should I bring my dad home since the nursing home is doing a good job? Jose, I have no idea what your dad's situation is. Talk to me. What is your dad's situation? Why do you want to bring him home? Why is he in the nursing home? Talk to me. It's a very general question that you're asking me here, right? So while I'm waiting for Jose to either connect with me here live on StreamYard, which is the quickest way. He was doing good, but now he's getting not that good. It looks like they don't want to help him even without oxygen. Trachea removed. I see improvement before, but the nursing is not helping. So he's got the trachea removed. Okay, what else is going on, Jose? Why is he in the nursing home? Why did he have a tracheostomy? What else is happening? Is he in bed? Is he out of bed? Is he talking? Is he walking? Does he have a PEG tube? Does he have any IV access? Tell me more so I can help you to take the right next step. And once again, I can only encourage you to talk to me directly on StreamYard here. Come on live to the show. I don't bite. I'm here to help you. And, have a look at our testimonial section where, how we help families in intensive care and how quick we help them, and I can do the same for you here while I'm here live on the hour. So, Jose, I need more information. And the quickest way to give me information is to talk to me live directly here on YouTube. Then I can really help you quickly. Don't be shy. Okay, so while I'm waiting for more information from Jose, I also want to read out a testimonial once again that we had this week. So she said, what's she saying? So we put out a blog post from a subscriber, a testimonial actually, and then when we sent out the testimonial via our email newsletter, we had a response from the person who actually wrote the testimonial. She said, "Thank you so much. I wrote this testimonial last year. Thank you so much for your support. My sister awoke even months later. She's going great. She's now fully conscious. No short-term memory issues. She's home with our family. She is learning to walk again. It was a long road, but we are glad that we never gave up. Now my sister can tell her own story." And that is from Chiquita. Chiquita was one of our members last year, and we have guided her through the intensive care journey with her sister one by one, step by step. The biggest challenge for families in intensive care is simply that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights. And they don't know how to manage doctors and nurses in intensive care. That was exactly what Chiquita was dealing with. And unless when you have a family member in intensive care, and if you're watching this and you have a family member in intensive care, you know that you don't know what you don't know, right? You know exactly that you don't know what you don't know. And unless you have someone holding your hand, guiding you, you'll be fighting an uphill battle. You'll be fighting an uphill battle. Okay, so Jose says, after his brain trauma, they say to turn machine off, I refuse. They say he never woke up or even opened his eyes. And after that, decided to do a tracheostomy. After I woke up, they keep him too long in ICU. He's an organ donor, and I see something weird about. Okay. Need more information, Jose, to guide you. And all I can tell you is come on here live on the show. I don't bite. And we can map out your questions very quickly, because that's what I do for a living, problem solving. I problem solve for families in intensive care. That's what I do for a living. Okay, so coming back, to our member from last year, Chiquita, you need someone to handhold you through this once in a lifetime situation that you simply can't afford to get wrong. I can't tell you how many families in intensive care come to us when their loved one has passed away. They come to us a year, 2 years, sometimes 5 years later saying, oh, my family member died in intensive care. I didn't know that there was any advocacy out there. I didn't know that there could be a second opinion. I didn't know that the intensive care team potentially might manipulate things. Again, they don't know what they don't know. And then they come to us and they say, oh, can we have a medical record review because I need closure? Well, it's too late by then. We're happy to give you closure. We're happy to do a medical record review and tell you whether they've done the right thing or not. But if you're getting advice now, if you're getting a second opinion now, if you're getting advocacy now, that is when you can turn the needle, right? And when you look on our testimonial section at intensivecarehotline.com, when you look on our testimonial section, when you look at our podcast section at intensivecarehotline.com, where we've done client interviews, it is no secret that we have saved many lives, and it's all documented, right? It's all documented. So, when you look at Chiquita's situation, her and the family were told, that her sister would die. And we said, we put the brakes on. We said, well, why would she die? 90% of intensive care patients actually survive, if you look at the statistics. So why would your sister die? She was only in her 30s. So, the younger a person now, of course, the higher chances that someone is going to survive. And if 90% of patients in intensive care approximately survive, why would you think that the odds are against your loved one? They're not. They're actually in favor of your loved one, right? So you got to go in with the right mindset, right? So number one, if you have the right mindset, then number two, let's look at the mechanics. Let's look at medical records. Let's look at what's happening on a day-by-day basis. Let's break this down. Let's do a crash course for families in intensive care. That's basically what we do. We give you a crash course, what to look for, what questions to ask, how to behave with intensive care teams. This is a difference in your behavior, that can make a difference, right? So Jose, you're saying they take advantage because I don't have my dad's power of attorney, even took my dad to Social Security, even themselves admitted at nursing my dad is better with us at home, and also fall out of the bed 3 times. Okay, Jose, if you do take your dad home, right, you do need to make sure it's safe. Obviously, you think that it's not safe in the nursing home. You think that your dad is better off at home. Well, if that's the case, go home, but make sure it's safe, right? Make sure it's safe. And I appreciate that you're a fan of mine. I appreciate that. I appreciate your support. And then you're saying, he fell out of bed 3 times and no attorney want to help me. I know my dad and I see he was doing good. I think they hold him on purpose. On purpose. They hold him on purpose. Yeah, that might all be the case, Jose. That might all be the case. I don't know whether they held him on purpose or not. I haven't looked at the medical records. I wouldn't know whether they held him on purpose or not. But the bottom line is this. With intensive care at home, if your dad has no tracheostomy, he can go home, right? There's no question that he can go home. The question is, can you put the resources in place to have him at home safely? The magic word here is safely, right? So, that's the bottom line. Do you have the space at home? Do you have the setup, right? You probably need some nursing care, right? What does that all look like? We can help you with that, We're providing a home care service as well. At least we can advise you what you need to put in place, because that's what it comes down to. How can you take your dad home safely, right? That is the most important question here. It looks like you're on the right track. It looks like you're on the right track, Jose. That's for sure. So it all comes down to putting the right. You've been fighting for 1 year to have my dad at home, but why? Because they're not helping him. Okay, so what stops you from taking your dad home? What stops you? What stops you from taking your dad home? Another sort of mindset that families in intensive care or families that are in similar situations have is they have a can-do attitude, a can-do spirit. So what I mean by that is you taking your dad home or not taking your dad home is entirely up to you. Get the resources in place. Is it a power of attorney issue? Okay, if it's a power of attorney issue, then you need to speak to a family lawyer. I am not a lawyer. I'm a clinician solving problems for families in intensive care or anything that is related to that, like your situation, Jose. I'm not a lawyer. I can't advise you on power of attorney. That is not my area of expertise. My area of expertise is to solve clinical issues, right? If you need power of attorney, go and speak to your lawyer. If that's the only holdup, go and speak to your lawyer and get power of attorney. Make things happen, right? That's the bottom line. Make things happen, right? So that's the bottom line. Make things happen. Don't make excuses. And I know that sounds harsh. But to get outcomes, you need to stop making excuses. If you're saying the power of attorney issue has held you back for the last year, change it. Change it. Make things happen. I don't know, Jose, if your dad can recover at home better than he's with you. And I tell you why I don't know. I would need to look at the medical records. Maybe you could send me a video of your dad or, I don't know. Right? I can only give you clinical advice if I have all the details. Right? Maybe they're not helping him because they're sedating him. Yeah, I understand. You're new to all of this. I get it. I understand that this is extremely challenging, Jose. I understand all of that. This is extremely challenging. Life is testing you to the maximum here. I get all of that, right? But by the same token, if the power of attorney issue is your first bottleneck, get it done, right? Get it done. That is the first challenge here. Get it all done. Get the power of attorney. Get the power of attorney done, and then take the next steps from there, right? Most patients are better off at home. However, you have to have the right support structure in place. If you don't have the right support structure in place, it's doomed to fail. And your dad will be worse off if he ends up back in hospital, if he ends up back in a nursing home. So to set it up correctly, you got to get it right from the start. Right? So keep that in mind. Keep that in mind. And by the way, Jose, I am not a doctor. I'm a critical care nurse. No one needs to address me. So I'm not a doctor. I'm a critical care nurse, but I have a ton of experience in intensive care as well as with intensive care at home. And like I said, I'm here to solve problems for families in intensive care or families that have loved ones coming out of intensive care. Right? You got to make sure that if you take your dad home, it's safe. And once it's safe, he probably is better off in a nursing home. But you have to make sure you're putting the right things in place. Right? So, yeah, you're welcome. You're very welcome. You're most welcome. So, go and get it done and give it a go, but also do some planning around it. Don't rush into it as much. If I knew you have the resources, I would say, yeah, go for it. But I don't know enough about your dad's situation. The other thing that I don't know is your location. Sometimes it can be a location issue. If you're in a metropolitan area, resources are less of an issue compared to when you are regional or rural, right? So some of it might come down to that as well. Okay, so let's move on. I told you a minute ago that we had a testimonial this week from Chiquita. And I want to read out Chiquita's initial email that we had when she first engaged us as a member, when she first engaged us for consulting and advocacy, so you can actually see how her situation changed, her sister's situation changed. So that was the first email that we had from Chiquita about a year ago. Hi, Patrick. I gathered some information about my sister. My sister is still in a coma. I was told that the sedation ended on the 6th of February 2024. However, my sister is still on seizure medications, which includes Keppra, Vimpat, Valproate. One of the doctors says that my sister's brain waves are slow on the EEG, like in a sleep state. I spoke to another doctor that says that sedation can slow down brain waves. My sister's overnight nurse informed me that my sister has gag reflexes, cornea reflexes, and a cough. She also flickers her eyes. The night nurse also stated that my sister appeared to be trying to awaken from the coma. However, the day shift nurse said that she saw nothing. When I asked about the medication that my sister was given, the day nurse stated that my sister was given 3 seizure medications. My sister woke up every day after her cardiac arrest until she was given seizure medications. The one doctor who was supportive stated that it takes longer for dialysis patients to fill their drugs because he has been off duty and the doctor who is covering him is very bad. My sister's CT scans came back normal every time. However, her EEG reveals sluggish brainwaves. According to the ICU doctor, because she has not awakened, she is in a vegetative state. I told the ICU doctor that the night nurse says that my sister tried to wake up. She says that doesn't mean anything. My sister woke up days after the cardiac arrest, but after taking seizure medications, she has not woken up. Is it possible for a person never to awaken from a coma? I spoke to a surgeon and he told my mum and that my sister is sedated. By the way, my sister flickers her eyes when I talk to her. She also positions her legs in the way she was yesterday. So, And then what else was there? Yeah, so the sister was 33 years of age. Obviously now she's 34. You know, she had a cardiac arrest, obviously, and things went very, very negative. And then 12 months later, Chiquita sends a testimonial and saying, thank you so much that, you know, you've helped me. And now my sister is back to almost normal, and she's walking, she's talking, even though we were told she's not going to survive. If she was going to survive, she won't have any quality of life. So it's another testimony that you have to think for yourself. You have to do your own research. You have to follow your gut. You know, you have to follow your gut. Right? That is really, really important. Okay, so then let's look at another case study that we are currently working with, another client that we're currently working with. Of course, I'll leave all client details confidential. I am not going to share any names, but I think it is important to understand what is really happening when a patient is on ECMO in ICU, because that's what we are currently dealing with. So if a patient is on ECMO in ICU, it is important for you to understand what's happening. So let's just quickly talk about ECMO. When a patient is on ECMO in ICU, there's two forms of ECMO. One is VV ECMO, which stands for veno-venous ECMO, and that is generally speaking for lung failure. So what VV ECMO is doing, it takes over the function of the lung so that the lungs can recover. It's often being used for ARDS, severe cases of pneumonia, and it is also often used at cystic fibrosis, scar tissue in the lungs, and so forth. And it can be used as a bridge to a lung transplant, right? Or it can simply be used for the lungs to recover. Okay, that is VV ECMO, right? It is an extremely invasive therapy form in intensive care. ECMO basically is like a bypass machine, right? And when it takes over the function of the lungs, you know, it needs to be monitored, it needs to be managed. There are many risk factors that need to be managed, right? And if the lungs don't recover, right, then a lung transplant might be the next step. Or if a lung transplant is not an option for whatever reason, unfortunately, patients have not survived their ECMO therapy. So let's look at VA ECMO. VA ECMO stands for veno-arterial ECMO, and that is being used for heart failure, right? So what is ECMO doing when it's used for heart failure? So in this particular situation, we're currently working with a client who has their 56-year-old dad on VA ECMO in ICU, and the reason they are on VA ECMO is they had a cardiac arrest with a hypoxic brain injury initially, supposedly hypoxic brain injury, right? But he's now waking up. It looks like his brain is intact, which, you know, just because someone had a cardiac arrest and they're telling you they've got a hypoxic brain injury, you got to wait and see what happens. Don't rush into conclusions. Don't jump to conclusions. Give it time. Give it time. So let's look at this patient situation who's been on VA ECMO since the 7th of January. At the time of the recording of this video here, today is the 26th of January. If you're in the US, it's still the 25th of January. So this particular patient is on VA ECMO, is on a ventilation mode, PRVC, with the respiratory rate set at 16 breaths per minute, with a pressure set at 400. Is on a PEEP of 5 centimeters of water and FiO2 of 40%. Is on medications, continuous IV amiodarone infusion, dexmedetomidine, also known as Precedex, which is a sedative, also on heparin, and also on a lignocaine infusion, also on sodium bicarbonate infusion. Now let's break this down. Why is a patient on such medications when they are on VA ECMO? So when someone had a cardiac arrest, the chances of the heart not beating properly, the chances of the heart going into irregular heart rhythm such as AF, like atrial fibrillation, or such as VF, ventricular fibrillation, or VT, ventricular tachycardia, is pretty high. That's one reason. So amiodarone and lignocaine are antiarrhythmic drugs. So they slow the heart rate down, and with those medications, there's a much higher chance the patient goes back into a normal heart rhythm while the heart is also recovering, because currently the heart doesn't need to do a lot of work because the ECMO is doing all the work. That gives the heart time to recover. Once again, the ECMO machine is like a bypass machine, taking over the function of the heart or the lungs. Now, this gentleman is on dexmedetomidine, also known as Precedex, which is a sedative. Why is he on sedative? Because he's ventilated with a breathing tube. So the breathing tube would be in the mouth, which would be very uncomfortable. And also, he shouldn't move too much because otherwise that could upset the ECMO therapy. Right? So, there is talk about a tracheostomy for this client or for this patient. However, there's an added-on issue that he's on heparin. Why is he on heparin? So for ECMO patients, the blood that's coming out of the body is running through a filter. It's running through plastic tubes, running through a filter where the blood gets oxygenated and carbon dioxide gets removed. Now, when blood is running through a plastic circuit, running through a filter, there's a very high chance that blood clots will build and will go back into the body. If they go back into the body, a stroke could be caused, right? Therefore, a patient needs to be on blood thinners. When a patient is on ECMO, they need to go on heparin. Heparin is a blood thinner. You need to target APTT in the blood results, making sure there's a certain range within APTT achieved so that the blood is not too thick but also not too thin, because if the blood is too thin, then the risk is to that there's a bleed occurring, which is a massive risk. So other medications this gentleman is on is some aspirin, some atorvastatin, some cefazolin, some cefepime, because he's also having a pneumonia at the moment, which is one of the biggest risks when someone is on a ventilator, by the way, that patients sustain a pneumonia. He's also on pantoprazole, he's on magnesium, he's on atropine nebulizers, he's on ticagrelor, which is another blood thinner, he's on vancomycin, pantoprazole, and simethicone, right? So why is he, for example, on pantoprazole and simethicone? Well, when patients are in intensive care, they are at high risk of gastric ulcers that could lead to stomach bleeding. It's a stress response of the body, right? Imagine how stressful it is for the body to be a patient in intensive care, right? And just like in normal life, many people get stomach ulcers if they have stress in their lives, right? It's the same in intensive care. So by giving patients nasogastric tube feeds, by giving patients pantoprazole, which is a medication that prevents gastric ulcers, and by giving them simethicone, you're preventing stomach ulcers. Now, next. The patient on the ECMO is currently on a pump flow, which is mils per minute, 660 mils per minute. He's on 100% of oxygen, and he's on a sweep O2 oxygen liters per minute 0.5, which helps to remove the carbon dioxide in the blood. The ECMO got inserted on the 7th of January. Intake output summary for the last 24 hours is intake is 3.5 liters, 3,400 mils, and output is 4,300 mils. That's a negative fluid balance of around 934 mils. Why is this important? Two things. One of the goals for this gentleman is to wean him off the ventilator. One of the goals is to wean him off ECMO. Now, if a patient is potentially having a positive fluid balance, that means there's more going in than out, and the patient would have that for multiple days. Chances are that a patient will end up with what's called wet lungs. There's wet lungs and there's too many fluids on the chest, on the lungs, there's a smaller chance of succeeding in weaning off the ventilator. Now, before this gentleman can be weaned off the ventilator, he needs to be weaned off VA ECMO, right? That should be the first goal here. So, also similar to what I just made reference to, sort of quote-unquote wet lungs, right? He needs a dry heart, right? So the heart needs to be dry, because if the heart is too wet and the heart has to pump too many fluids around, there's a smaller chance to succeed in weaning off ECMO, right? So fluid balance in intensive care is very critical, very critical. It also goes on the other hand, I don't want to digress here, it also goes on the other hand, sometimes patients are hypovolemic, meaning they haven't got enough fluids on board, right? And as long as their heart and their lungs can tolerate it, they need to be given fluids, right? They need to be given fluids. Now, this gentleman is also on dialysis, right? It's reasonably easy to control dialysis, reasonably easy to control fluid output or fluid balance, reasonably easy. Then furthermore, just give me 1 second, I just need to go back quickly into my documents, which here they are. So then, what's the progress for a patient like this? Let's read out the doctor's reports. Acute kidney injury in the setting of cardiac arrest and cardiogenic shock. Non-noliduric, that means the patient is still making urine, but it's still the patient is making urine, but it's not clearing out all toxins. So we will hold the CRRT tomorrow and see and monitor, right? So CRRT stands for continuous renal replacement therapy, right? They will be holding the dialysis to see whether he can make more urine, which would be good, because if he doesn't need the dialysis machine, that would be ideal. Next, hyponatremia, mild and stable. Sodium is 132, continue to monitor. Now we're digging down deeper. So I said the patient has a negative fluid balance. So one way to assess fluid balance also is to look at sodium levels. Sodium is 132, which means it's mildly hyponatremic. It's mildly not enough. If sodium levels are too low, it says, or it suggests that a patient is hypervolemic, meaning they've got too many fluids and water on board. So that means they need to clump back on fluids. They need to achieve a negative fluid balance to get the sodium back up to normal levels. If a patient is hypernatremic, meaning the sodium is too high, there's a high chance he's dehydrated. Right? And if a patient is dehydrated, assuming the heart and the lungs can tolerate it, you need to give them fluids. Next. He's got sepsis, he's got RSV, influenza, community-acquired pneumonia, aspiration pneumonia, antimicrobial regimen as per primary doctor. So he's got pneumonia because he aspirated at some point. And like I said, it is also much more likely that someone ends up with a pneumonia when they're ventilated in ICU and they can't mobilize. A patient with ECMO, with VA ECMO in particular, can't mobilize. Very difficult. You know, you've heard me say in some of my other videos, mobilize, mobilize, mobilize. And I always say the exception is if someone has multiple trauma. The exception if someone is hemodynamically unstable, which is definitely the case for someone on VA ECMO. So then, let's look at the doctor report in more detail. I have reviewed the patient's history and physically re-examined him. Note the following changes. VA ECMO via bilateral groin access with right SFA antegrade perfusion catheter and left groin impeller. Planning for removal today once impeller 5.5 is in place. Now, what's an impeller? An impeller is basically a left ventricular assist device, also known as LVAD, left ventricular assist device. What's an impeller or LVAD doing? It's taking over the function of the left ventricle of the heart, right? So if it's taking over the function of the left ventricle of the heart, that means ECMO might be able to remove. But let's dig down deeper and let's look at more of the doctor's notes. So it's day 17 of ECMO. Patient was seen and examined in cardiac ICU during multidisciplinary ECMO rounds. Remains critically ill, intubated on the ventilator, ECMO support, and CRRT. CRRT once again stands for continuous renal replacement therapy, also known as dialysis. INR is 1.1. Hemoglobin is 7.9, platelets are 133,000, on heparin at 1600 units per hour, continues to receive ticagrelor because he's got a stent in his heart. He's got stable fibrin collection and post-oxygenator, anticipating decannulation today. Not commanding lower extremities, but will now not hit yes or no appropriately and command appropriately. Is having ooziness from bilateral groin sides intermittently. Plan for decannulation to 5.5 impeller tomorrow. Family understands he needs to be ambulatory and off CRRT before an LVAD would even be an option. Now, an impeller is basically a small LVAD, but once the impeller is stable, then LVAD could be used. Recommendations. Continue heparin, titrate to a APTT 60 to 80 seconds until procedure prep. Once again, this is why it's important. The APTT is basically a coagulation marker in the blood. If APTT is high, patients are at risk of bleeding. If APTT is low, patients are at risk of developing a DVT, a deep vein thrombosis. Next. Obviously, full blood count needs to be done daily to monitor for bleeding or thrombocytopenia. Use Brilinta per cardiology if the patient's because of the patient's history of stents, if platelets are greater than 75,000. Keep INR less than 2 with excessive bleeding, less than 3 without bleeding. INR is another coagulation marker in the blood. If INR is too high, again, there's a higher risk of bleeding. If it's too low, there's a high risk of blood clots. It's about finding that line. Then next, transfuse units of blood to keep hemoglobin about 8. And if hemoglobin is too low, which is a risk when someone is on ECMO and dialysis because you're losing blood by running blood through the filter, right? Then there's also a higher chance that if hemoglobin is too low, that once again, patients are too dry, they're dehydrated. And number 2, there's also a higher risk that patients need inotropes or vasopressors to be weaned off ECMO, and you need to avoid that, ideally. So, and then progress notes continue. From the ICU doctor. Discussed with cardiac surgery regarding transition from VA ECMO to impeller. 5.5 support today. The patient will need vascular repair, which is no surprise because when they take out the ECMO cannulas, there can often be a gaping hole, and that's when in the veins, and that's when a vascular repair might come in. If he achieves renal recovery and improvement of neurological status to the extent that he's ambulatory, the LVAD could be a consideration. We understand that this strategy is unlikely to succeed, but we want every attempt of recovery. We will increase ultrafiltration today as tolerated on the CRRT. We need to avoid inotropes with a history of refractory ventricular arrhythmias. And I agree with that. You need to avoid inotropes wherever you can, because if you're using inotropes, that means the heart is not really working. That's number one. And number two, like it's highlighted in the report, there is a higher risk of patients going into arrhythmias, and you don't want that. You don't want patients going into or having arrhythmias, right? That wouldn't be any good, and it would be detrimental for someone on ECMO to recover, right? When someone is being weaned off VA ECMO, you want the heart to beat as independently as possible, right? That is always the goal of ECMO therapy. Always. Okay, so then the ICU doctor's report continues. He's still ventilator dependent, and we discussed a tracheostomy. We are hesitant, but we would consider it if he has persistent ventilator dependency after Impeller 5.5 implantation. So here's the risk with tracheostomy for ECMO patients. Doesn't matter whether it's VA ECMO for heart failure or whether it's VV ECMO for lung failure. Patients on ECMO, 99% of patients on ECMO are on heparin for the reasons that I explained before. Because when the blood is being filtered through the ECMO machine, going through plastic tubes and going through a filter, the risk of blood clots to form and re-enter the body is very high, or the risk for blood clots to get stuck in the filter and blocking the ECMO machine, leading potentially to another cardiac arrest, is also very high. So therefore, you've got to give the heparin, which is the blood thinner, to keep the blood as thin as possible, but not so thin that someone is at risk of bleeding. Now, here's the risk. When a patient on VA ECMO and ventilated can't be weaned off the ventilator and is at risk of that, and is at risk of needing the ventilator long term, they can only have a tracheostomy once heparin is off. If you stop the heparin to do a tracheostomy, the risk that a patient will end up with a clot that could cause a stroke is very high. Now, one of the risks that hasn't been pointed out in the report yet, and it might be pointed out down the line, is even if a patient gets weaned off VA ECMO, and even if a patient is going on the impeller, they will still need heparin. The heparin is not going away, even though the impeller is a much smaller pump. It's still running through metal then. The impeller is usually made out of metal, right? And if it's running through the impeller, there's still a very high risk of blood clots to develop, and that still needs heparin to manage that. So, plan. What's the plan here for a patient like this? Let's read out the doctor's reports. Continue ECMO support, and then going on to the impeller to support the left ventricle. Plan for placement of impeller 5.5 with likely removal of ECMO support on the 24th of January. Ultimate goal will be to liberate him from all cardiovascular support. Also to avoid inotropic support based with a history of the VT, the ventricular tachycardia, causing the cardiac arrest. Long-term management is dependent on neurological improvement. Well, the good news is he's now obeying commands. You know, he's now obeying commands even though he's still on sedation with the Precedex. Next, anti-arrhythmic therapy with amiodarone and lignocaine. The trending is to wean amiodarone and lignocaine. And like I explained in the beginning, Lignocaine and amiodarone are both antiarrhythmic drugs for the heart, right? Amiodarone is generally speaking given to avoid any AF atrial fibrillation, and the same for lignocaine, it can be given to get patients back into a normal sinus rhythm. Next, trend and organ function and lactate. So, and trend SVO2. What's SVO2? SVO2 is a mixed venous blood gas, and you can get that if you have a Swan-Ganz catheter in place. Right? What's a Swan-Ganz catheter? The Swan-Ganz catheter is a catheter that goes through the heart sits in the pulmonary artery, and there you can get a mixed venous gas, and you can also get cardiac output and cardiac index studies, which is very important for a patient on ECMO. Now, it is not clear to me that they have a Swan-Ganz catheter or a PA catheter in place, pulmonary artery catheter in place. I'm not sure about that. It's not clear, but if they do want to measure a mixed venous gas, they must have a Swan-Ganz catheter or a PA catheter in place for this particular patient. Next, because they can now measure cardiac output, cardiac index, it's also easier to wean off ECMO to see what's cardiac output, what's cardiac index doing once they wean off ECMO. If cardiac output, cardiac index keeps improving while they wean off ECMO, that's when things are moving in the right direction. They need to monitor lactate. Lactate is also a very good indicator whether all organs are perfused well enough with oxygen. Simple reason is if organs are not perfused with oxygen, lactate is rising. Lactate is rising. Next, heparin for left ventricular thrombus history and ECMO protection. Hematology is following up. So once again, it talks about ECMO. There's a history of a thrombus in the left ventricle, which is probably what led to the cardiac arrest. And then next, transfused blood products as per hematology recommendations. Like I said, it's important to keep hemoglobin up. And that is the plan for this particular patient. So, that's really good that they've got a plan. Hopefully I can give another update here next week in another YouTube live, to see where their dad is going. But I'm positive he's moving in the right direction slowly, very slowly. Okay, now, before I move on to the next question, type in your questions into the chat pad, or talk to me directly live here on the show. Click on the StreamYard link that I will just post here. Once again, I've got another 10 minutes to go. But I will wrap up here in about 10 minutes. So you still have the choice to talk to me directly here or type any questions into the chat pad. Let's look at other questions that have come in during the week. So here's an email from Sophia. Sophia says, "Hi Patrick, my 77-year-old dad was admitted on the 27th of December with pneumonia and an undiagnosed infection. Now he's been in an induced coma for 8 days. My family are not very assertive, but I'm the one that is. He's got bleeding in his stomach, clots in the lungs, now he's bleeding from the mouth. A meeting was scheduled for yesterday and postponed until today, and now that time has been pushed forward for 2 hours. Are they hoping my dad will just pass away, so they will have to do nothing more?" Okay, so let's break this situation down for your dad here, Sophia. He's got a pneumonia, he's got an undiagnosed infection, and now he's been in an induced coma for 8 days. He's got bleeding in his stomach and he's got clots on his lungs. and he's bleeding from his mouth. So here is what I'm reading into the situation. I do believe your dad would have had a PE, a pulmonary embolus, which is why he had clots on the lungs. They would have started him on heparin to break down the clots and prevent any future clots. And similar to ECMO, when a patient is on heparin, they need to manage APTT. APTT is the clotting factor that needs to be monitored. So usually when a patient goes on heparin to prevent any blood clots, right, APTT needs to be monitored. Usually they might give a range of 40 to 50, sometimes 40 to 60, sometimes 60 to 80, depending on the situation, right? And now they've probably gone over target, which is why your dad is bleeding, right? And if he's bleeding in the stomach, that has its own risk, including, he can't have any feeds, or it's difficult to feed him, or he can't have the full dose of feeds. If he can't have the full dose of feeds, does he need some TPN, which is intravenous nutrition? Next, they had a scheduled meeting. They had scheduled a meeting for yesterday, and now it's postponed until today. And now it's been pushed forward for 2 hours. Are they hoping he will pass away, so that they will have to do nothing more? Now, Sophia, here's the thing. They have a meeting scheduled. What are you going to do about it? What are you going to do about them scheduling a meeting? Will you just go? How are you preparing for this meeting? Will you just go and have them walk all over you? What are you doing to take control of the situation? Now, I don't know whether your dad can survive this or not. I have no idea. I don't have enough information. I would like to know, for example, what medications he's on, what are his blood results, what ventilator settings is he on. I would like to see a full evaluation of his current situation. That's when I could really guide you in much detail. But one thing is for sure, you are worried about that they let him die. So would you just walk into the meeting without your agenda? Will you just walk into the meeting because they ask for it? Have you asked for a written agenda for the meeting? I would if I was you. I would. So let me ask you this. I don't know anything about you, Sophia, but let's just say you are working for someone, or you have worked for someone, whatever the case may be, and you have a meeting. How many times do you have a meeting agenda when you go into a business meeting? Well, most of the time, isn't it? So would anyone in their right mind go to a meeting in intensive care that is potentially about life or death without an agenda in writing? Think about that. We're having agendas for meetings all day long, for all sorts of life events and business meetings and whatnot. And you're just walking into a meeting blind without a written agenda. You must be out of your mind. So your first step here is to ask for an agenda in writing, and in the meantime, demand to continue best care and treatment for your dad. Once you've seen the agenda in writing for the meeting, then you decide whether you go, you don't go, you get me into the call. I would not go into any meeting without any clinical representation of someone who understands intensive care inside out. I would not do that, not in a life or death situation. I would also not go into a meeting until you've got access to the medical records, full access to the medical records, and have a second opinion, have someone like us look at it and give you a breakdown of what's exactly happening. What are your dad's chances? Once again, remember what I said in the beginning, 90% of intensive care patients approximately survive. So why would your dad not survive? Right? You have to think about those things. You have to be strategic, very strategic. If you're not as strategic about these things, they will walk all over you. Your gut is already telling you they potentially don't want him to live. They potentially don't want to help you as much as you would like to see it. Your gut is already telling you that. So make arrangements, manage the situation. The problem is that most families in intensive care don't even know that managing a situation like that is possible. But you need the right advice, you need the right tools. Right? Really, really important. Anything is possible as long as you know what to do. If you don't know what to do, you'd be fighting an uphill battle. And then you'd be coming to me later, 1 year later, saying, oh, my dad passed away and I don't know why, and I want to know why. I wonder whether we've done the right thing. Well, now is the time to do the right things, not in 12 months' time. Now is the time to do the right things, not in 12 months' time, when it's too late. So, I'm going to wrap this up here in a minute. Once again, thank you for watching. Like the video, subscribe to my YouTube channel. If you like the work that I'm doing, click the notification bell, share this video with your friends and families who have potentially family members in intensive care or need intensive care at home. And comment below what you want to see next, what questions and insights you have, so I can keep making content that you are interested in. Once again, if you need consulting and advocacy for families in intensive care, go to intensivecarehotline.com, call us on one of the numbers on the top of our website, or simply send us an email to support@intensivecarehotline.com with your questions. We have a membership for families of critically ill patients in intensive care, and you can become a member if you go to intensivecarehotline.com. If you click on the membership link, or if you go to intensivecaresupport.org directly in the membership, you have access to me and my team 24 hours a day in the membership area and via email, and we answer all questions intensive care related. In the membership, you also have exclusive access to 21 ebooks and 21 videos that I have personally written and recorded, and all of the information will help you to make informed decisions, have peace of mind, control, power, and influence, making sure your loved one gets best care and treatment always. I also do one-on-one consulting and advocacy over the phone, Zoom, Skype, WhatsApp, whichever medium works best for you. And I talk to you and your families directly. I handhold you through this once-in-a-lifetime situation that you simply can't afford to get wrong. I also talk to doctors and nurses directly with you or on your behalf, and I ask all the questions that you haven't even considered asking. We also do medical record reviews in real time. We also do medical record reviews after intensive care. All of that you can get closure, can get a second opinion. I also represent you in family meetings with intensive care teams. And if you need intensive care at home, go to intensivecareathome.com, where we send our critical care nurses into the home 24 hours a day, all around Australia. And if you're in the US or in the UK, we can do the same for you there privately. So reach out to us at intensivecareathome.com. Thank you so much again for watching. I'll see you again next week at the same time. Keep an eye on the quick tip videos that I post during the week. Thank you so much for watching. This is Patrick Hutzel from intensivecareathome.com and intensivecarehotline.com, and I will talk to you in a few days. Take care for now.